We're covering a lot of topics, but relax, we'll try and do it sort of informally. I was a GP in Edinburgh for about 31 years. I have an interest in medical legal matters. I was a police surgeon for a number of years with Lothian and Borders. That means doing forensic examinations and rape and murder and stuff. I'm sure you'd prefer to hear about these sort of things than boring medical conditions, but we're going to really have a broad overview. My experience is very much as a family doctor, that I have a medical legal bent, as I said. I still give opinions in litigation, very rarely criminal activities now, but in alleged negligence cases. So I have a kind of skewed view of mankind in some ways, but I've also, my best friend is Donald Cameron, who's director of optics or optometry for NES, and as I said, my son Kevin is an optometrist, so I'm very empathetic to your clinical values and skills. So, general health, where we go. We're going to deal, first of all, with cardiovascular disease and hypertension. Cardiovascular disease, as we know, is a huge cause of death. I'm a little suspicious about the Scottish statistics, however, because there's very rarely post-mortems done in these type of deaths. And there's a strange sort of thing in Scottish law where if the GP is unable to give a cause of death, the fiscal can ask the local pathologist to do a view and grant, which is a very funny thing, which is just looking at the body, saying izzy wizzy, and granting a death certificate, which is pretty bizarre, because obviously by looking at the outside of a body, you're not actually going to tell what's inside. So in fairness, knowing the patient's history, and he comes from the west of Scotland, and he's had, pies and chips and whatever for all of his life, it quite often will be accurate, but in other times I think it's quite a tendency to misdiagnose, and the statistics therefore I think are a wee bit dodgy for some areas of Scotland, but I wouldn't like to go public on that. Hypertension, of course, is a major cause of death as well, and we can see why just in a minute. The cause of hypertension is basically unknown, and that's why they say it's essential hypertension. There's all sorts of theories out there, but as far as I'm aware, there's no definite cause being found for the vast majority of high blood pressure. There are some that are secondary causes where you get stenosis, in other words, the renal artery is a bit narrowed, and others the same thing, you can get narrowing of the aorta, and then there's one or two weird and wonderful sort of endocrine causes. But most high blood pressure is unknown. Risk factors, well, why do we treat? Well, it's quite simple, really, as if the pressure in the system is too high, it's going to cause damage to the pipework, the blood vessels, if you like, and therefore you're at risk of a stroke or ischemic heart disease. So that's why you want to keep the pressure low in the system. When you treat, well, these are the sort of numbers. You don't just take one blood pressure reading because, I don't know if you, but certainly I am very anxious when I go into a doctor's surgery, and my blood pressure is probably pretty high. So you take an average, it's recognized that a 24-hour BP assessment at home, which is done automatically, gives you a good profile, or even if you get one of these proper kits like an Omron one and do it yourself at home through the week, you'll get a more accurate profile. So you'd certainly want to measure at least 3 blood pressures at different times to give you a sort of average. And you'd want to treat if your blood pressure is significantly sustained above 160/100, or maybe even as low as 140/90, depending on other factors. And these factors are, obviously, if you've had a history of cardiovascular disease, in other words, if you had a heart attack or a stroke, you want to get that pressure down as low as possible. If there's evidence of target end organ damage, and you'll see that in the eyes when you see retinopathy, or if they have nephropathy, in other words, kidney damage, and there's protein leaking out in the urine, and there are other areas of organ damage. And then if your cardiovascular risk is greater than 20% at 10 years. Now, these are these things on these colored charts. You might have looked if you've got a copy of the BNF at the back. You can plot your age, your cholesterol ratio of good cholesterol to bad cholesterol, and your smoking habit and other things like family history. This will give you an estimate of your risk of cardiovascular disease, and it's deemed that if your CVD risk is greater than 20% at 10 years, they would certainly recommend lowering your blood pressure and treating your blood pressure, lowering your blood pressure and also lowering your cholesterol by statins. We'll come on to that. Those of you who are alert will see there's a debate at the moment that NICE in England are recommending that that goes down to 10%, which would mean that particularly for males, for guys, almost the whole population would be on a statin aged over about 50. So it's quite a controversial sort of thing, and you might want to come back to me on that. Please feel free to ask questions. In a minute or two, I'll start asking you questions just to check you're still with me. But please interrupt at any time. Treatment? Well, it's the usual stuff, lifestyle, reduce salt, and the sugar police are out there actively too now. They're saying reduce your sugar level as well. Certainly reduction in salt intake, and some people, particularly if you watch them in the chippy, you see them, they turn the salt cellar and it keeps running. You know, a little salt is fine, but some people load a huge amount of salt on things, and there is evidence for that. Reduce your weight. You can significantly bring your blood pressure down by weight reduction, and you might get away without blood pressure tablets. Increase your exercise. I notice they're taking that very seriously today. There's all sorts of people running about in tracksuits and shorts and stuff. I thought I was at the wrong event when I got out of my car. Reduce alcohol. Certainly that's a very significant cause of raised blood pressure and cardiovascular disease. We'll come back to him in a little. Reduce stress. Well, enough said. Medical treatment. Well, our aim is to get the blood pressure down below about 140/85. But look at that, in diabetes, you're aiming to get it down to really very low normal levels. That's because diabetes, and we'll come on to that in a later bit, causes macrovascular damage, and it really knackers the blood vessel walls. So you really want to get your blood pressure down as low as possible to minimize the damage. So diabetics will have very tight control on their blood pressure. And then types of tablets used. And the other thing to bear in mind, and remember when you're taking a history, maybe of your patient, your client, they'll almost certainly be on 2 medications. There aren't that many people with sustained high blood pressure who will be maintained just on 1 medication, so you'll have a mixture of 2, and the common things are something like an ACE inhibitor. You know, these are things like captopril, lisinopril. It's the ills on the end of the common one. Alpha blockers aren't so common. And then ARBs, if you remember some of your pathophysiology, that's angiotensin renin blockers, which is working on the same pathway as your ACE inhibitor, which is your angiotensin converting enzyme. It works on the kidneys, that's all you really need to know. And beta blockers are still out there. They have significant side effects, we'll come across them. Calcium channel blockers are very common. They're things like amlodipine and stuff, and a lot of your old ladies, your old trouts will be on them, and they might have their sort of swollen ankles that you might notice puffing out and beneath the chair. The thiazide diuretics, very common. They're water pills that the lady or the wee grannies will be talking about, the thiazide diuretics. And then, of course, you'll almost certainly be on a statin or aspirin as well to prevent further vascular damage. Side effects, well, beta blockers. Cold extremities is particular now as we're going into the autumnal days. You might notice the wee grannies come in with their gloves and stuff because they get white finger. Some people need to wear gloves almost all the time with beta blockers because they shut down the peripheral vasculature. Wheeze is quite common. Asthmatics can be killed by putting on a beta blocker by mistake. I was involved in one case where a GP rather forgot the patient was asthmatic and started the patient on beta blockers. The patient over a number of days got wheezier and wheezier, didn't realize the problem, and sadly keeled over and died. And what made it absolutely awful was the GP proceeded to go back into his computer records and to delete any previous evidence that he had asthma. But of course, when it came, further investigation was done, suspicions were raised. They did an audit of his computer and found out these deletions. A wee bit like Shipman. Remember, he altered all the records retrospectively. And that GP was not only negligent, but was actually convicted of culpable homicide because of his actions. Just remember, just as a wee throwaway and as a wee frightener, timoptol, timolol can have that effect too. It's a wee bit unlikely, but there is significant systemic absorption, so asthma you need to be careful of. Beta blockers really slow people down. They get really tired for the first few days. Normally it passes, but not always. And they get quite a significant bradycardia sometimes. Their heart rate can slow down quite a bit. And then your ACEs or your ARBs, your angiotensin conversion enzymes and your angiotensin renin blockers, because they work on the kidneys, they can produce quite an electrolyte disturbance. And you can forget things like that. If somebody gets an acute gastrointestinal illness, in other words, they're dying from both ends, you can lose a lot of fluids, a lot of electrolytes, and if you forget, you might actually not tell them to stop that medication, and you can end up in real problems with kidney renal failure. And as I said, renal failure can come along, particularly as these sort of medications are used in your elderly age group, that you might not realize that the person who's going off slowly is actually getting kidney failure, partly because of the medication you're giving them. The other thing is postural hypotension. These tablets always used to be started very cautiously and carefully. They're not now so much, but it is amazing when you think about it that when we jump to our feet, we don't always immediately fall over, because there's incredibly complex changes take place within these few milliseconds to keep our blood pressure up sufficient to keep our brains alive. And there's very complex, receptors that have to vasoconstrict the blood vessels to stop all our blood falling to our ankles. And that's a wee bit compromised when you're on these sort of medications. So you can get people a wee bit lightheaded when they stand up. Cough is a very common side effect of ACEs, and just you might be aware of that in the... No, I think you're okay, but you might be aware, it's that sort of cough, it's just a wee sort of dry tickle. And sometimes people forget that it's a very common side effect. 10% plus of people who are on ACEs get that dry, tickly sort of cough. And if a patient complains of it, it might be worthwhile, if you've taken their history, just saying, might be worth thinking about it, because you can change that completely by changing from an ACE to an ARB. Other common side effects, as I mentioned, the calcium channel blockers. These are things like amlodipine and stuff. They cause a lot of fluid retention, so you get a lot of ankle swelling, a lot of edema, fluid around the ankles. They're rate limiting, some of them, so in other words, they can slow the pulse and stuff. And then aspirin and warfarin, which are given to thin the blood, and we'll come on to that for various other conditions. Their main effect, of course, is bleeding. And warfarin is a bit of a nightmare. I mean, the evidence for warfarin preventing strokes and heart disease is very substantial. But I'm a bit suspicious and somewhat cynical of all the studies, because the studies are so sort of well controlled that these people are so monitored that they will produce good results. But by definition, the chaotic people that keep taking the wrong pill at the wrong time, or it is a nightmare, because you're constantly having to take blood tests to check their how thin the blood is, their INR, international ratio. And if they get it wrong, you have to reverse it, and they have bleeding and stuff like that, and it's a major problem. And aspirin, likewise, though it doesn't need monitoring, is a great drug, aspirin, but if it was released now, it would not stand a look in terms of getting a license, because it's so lethal. People are dying of aspirin every day. Even today, people will be dying from aspirin, but it's a great drug. Of course, you read almost every Sunday Mail or the female section of Sunday Mail. It gives you all sorts of reasons why you should be taking aspirin to prevent colorectal cancer and all that sort of stuff. And a lot of people do, but the evidence, again, is pretty limited because it's the risk-benefit. And there are some people that definitely should, like diabetics or people with proven cardiovascular disease. The evidence is very clear. But for the other sort of fit person, probably not. Other people don't think of it as a pretty potent medicine, and you might take it for years and years, and then you'll find quite often that this person has an unexplained anemia. And then if you quiz further, they've been taking aspirin, so they've had occult bleeding into their gut for years, or sometimes a dramatic hemorrhage, and you take, oh, you've been taking aspirin, and they thought it was all good. It's like people take all sorts of naturalist and herbal cures without really thinking about it. I don't know, there's something out there that alternative medicine seems to be good. Now, I don't knock it, but most of it is totally untried and untested, and they consume all these multivitamins and St. John's wort, and some of them have quite toxic side effects. But because it's alternative, it's okay, but conventional medicine is bad and poisonous. And a lot of people don't think about aspirin, but it causes amazing, mainly GI, stomach hemorrhage, and it's a major cause of people having major bleeds. So you're just going to be careful with aspirin. Diuretics, well, urgency. Well, running to the loo, we said that. Gout. Very common if you get somebody in. But gout, remember, doesn't always just come with a swollen big toe. That's the commonest site, but it can come in other areas. It's an acute chemical arthropathy. In other words, the joints just flare up and get sore. So you can get it in your knee, your shoulder, and everywhere, not just your big toe. And one of the commonest is a thiazide diuretic as a side effect of that. And we've talked about renal failure. If you're giving water tablets, obviously you can get dehydrated. Statins, again, these are simvastatin, pravastatin, all these ones that we're talking about. Remember, of course, you've got the usual thing of the drug name and the generic name and all that sort of stuff, Lipitor and things like that. They cause an amazing amount of muscle pains, which is really, I think, over the years been played down, but it's quite a significant side effect. I would think up to about 30% of people don't tolerate the statin they're put on initially, and they get really severe aches, and you've got to try moving them through different types of statins, but it's quite a significant myalgia, in other words, muscle ache. Nitrates, headaches. Nitrates work for angina. They're the wee pills that people take under their tongue, or more commonly now a GTN spray, glycerol trinitrate spray. Now remember, don't get confused between asthma inhalers, we'll come on to that, and the GTN spray. The GTN spray is used for angina if they get pains and they might come into your consultant room and a wee bit anxious and have a wee bit puffer. That works to dilate the blood vessels in the heart, hopefully to lessen the ischemic pain, the angina-type pain. But the other problem is it dilates the blood vessels in the brain and gives you a bit of a headache as well. Can also, because of that vasodilation, reduce the blood pressure, and they're that much more likely to faint and have a syncope. I don't know if many of you have had patients fainting in your consulting rooms. It's not that uncommon. You're anxious, you're hot, you're sitting up, you're doing things to their eyes that they don't particularly like. So it's quite common. I mean, it won't be that common, but I bet you, can we have a show of hands how many people have fainted in the AC? Look at that. Almost, well, it's a great majority, and you know how to respond to it. It's a wee bit of a side effect, but don't leave them sitting up in the chair, because that's the worst possible position. Because a faint is just lack of blood to your brain. So if you leave them sitting up, they're not going to get blood to the brain, and you can have all sorts of things. They can have hypoxic fits and incontinence and all sorts of things if you leave them sitting up. And that's not very good, because if they start fitting, you think, well, are they epileptic? Is there something else going on? And you won't like that. So you must get them down on the ground. Don't try this business of getting the head between the knees and that sort of stuff. I mean, it doesn't really work that way. So you just have to get your instruments out the way, shout on your receptionist, Eileen, I need help here, or something like that. And just, I mean, it can be quite difficult, particularly if you've got a biggish patient, but you give them really just a big cuddle. That's why you need your receptionist coming in as well, because it can look a bit odd if the patient comes to and you're lying beside them on the ground. A big cuddle, and just get them slowly and carefully onto the ground. And it can be quite difficult getting them out of your chair with the arms and stuff like that. So you've got to, don't just pull their feet and yank them, but get them down on the ground, and if you need to, just gently lift their legs. And, within seconds, hopefully they'll come to, but leave them there for a while. Because if they say, oh, I'm fine, they'll be all embarrassed and covered in confusion, but leave them for a while, because if you sit them straight back up again, the same thing will happen. And then if you get them up and you give them a glass of water or a cup of tea or something like that, just to help their circulation. And I wouldn't suggest you carry on with whatever nasty thing you're doing to their eyes unless you're very confident, because the same thing might happen again. Are you happy with that? It's just a wee side effect. It's basically just first aid, but it's the sort of thing that can and will happen to you quite commonly, and you need to just have a wee bit of a strategy for that. Digoxin, well, it's not used all that commonly, but it is still to control heart rhythm. It's nauseating and it can slow the pulse quite a bit. Risk factors for CVD, you've got them on the list, but you can see them. They're standing out at the bus stop waiting for the bus to Shettleston in a shell suit, probably. You don't know their family history, but you can probably tell if you see them standing beside their mother. Isn't it frightening? I was looking at a young woman the other day, and her mother came along. I thought, does she not look at her mother and see what she looks like? One of these muffin top jobs and stuff like that. I thought, man, but you can't choose your parents, but unfortunately that's a significant risk factor. If your parents have had serious cardiovascular disease, you need to take note, because you're greatly at risk. And, obesity and diet, we see it so sadly, don't we? And that's a huge risk factor, and it's increasing. Remember a few, 10, 20 years ago when you went to the States, you used to think, man, they've got a big problem over there. You see these big fat wobblies wandering around, but now they're here, and it's just us. It's just because of our diet. High blood pressure, major problem. And of course, the obesity will put your blood pressure up as well. Hyperlipidemia, their lipids are probably all wonky. And remember, it's not just your total cholesterol, it's your ratio, because there's two types of cholesterol. There's high-density lipoprotein and low-density lipoprotein. HDL is cardioprotective, so you might have a total raised cholesterol, which is quite high, but if a significant proportion is of the good stuff, HDL, then that'll be quite protective, but hyperlipidemia in that sense. And then diabetes, you see, they're still at the bus stop in their tracksuits, and they've got probably obesity-induced diabetes. Lack of exercise, they're waiting for the bus, they're not walking themselves, or even worse, they're getting a taxi home from Tesco. Smoking, you see them smoking as well outside the pubs, and you add all these together, and it's amazing, isn't it, how some people actually survive when you have all these risk factors added together. And it's not just the west of Scotland, but it is particularly weighted to the west of Scotland. And how do we treat it? Well, lifestyle changes. We get them exercising and all that sort of stuff if you can, reduce their diet, healthy eating, less of the McDonald's and the pies and chips and the Coke and stuff like that, reduce their weight, increase their exercise, get them to stop smoking. You've heard it all. It's health education, isn't it? And reduce the alcohol. But easier said than done, isn't it? Questions on that? You okay? Still with me? Operative treatment, cardiovascular disease is quite interesting. There's always been availability for treating damaged heart valves. Rheumatic heart disease is when the heart valves are damaged and start leaking. You can replace them with valvular replacements, and that's an indication for needing warfarin. If they're an artificial heart valve, you've got an increased tendency to clots form and therefore suffering from embolic stroke, so you need to thin the blood post-operatively by replacing the valves. Then there's congenital heart disease, where they can do amazingly clever things, particularly now in York Hill here, with children having all sorts of shunts put in different pathways in their abnormal hearts. Endocarditis is quite common, which is a side effect of blood poisoning, septicemia, where you get vegetations or infection on the leaflets of the valve. So you imagine if the valve has a leaf like that, opens and closes, if you get vegetations forming on the edge of the valve, it leaks and doesn't form properly. So they have to have surgery done for that. So endocarditis is quite a significant infection. And then the big area that's come is the putting in of stents for ischemic heart disease. Ischemic heart disease, of course, is where the cardiovascular circulation is impaired, where the blood vessels within the heart muscle become narrowed. And we stents, you've seen them, are like little springs that are put in, and then they spring open and they hold that narrowed area open. There are different types of stents. There's plain metal, bare metal ones, and there's drug-eluting stents, which actually release drugs. And then you hope that over years the endothelial will form round the stent and give you a nearly normal circulation. And that's made a huge change to the treatment of ischemic heart disease. Interestingly, if you read the journals, though, it doesn't actually increase your lifespan all that much, but it will stop you having angina and stuff like that. And that's made a big reduction in coronary artery bypass grafting, or cabbages as we talk about it in the trade. And you have a number of patients that have had either stents or cabbages done. And obviously the artery bypass grafting is where the blockage, the occlusion, is more extensive than just one area. So you can't put in stents, you can't fix all these areas. So you've literally got to bypass it by taking a vein, normally one of the long veins out the legs, turning it the other way around, because of course you've got valves that stop backflow, and putting it in the heart and really bypassing the blockage so that you get blood supply to the areas that weren't before. But that's major heart surgery. I mean, that's open heart surgery. That's the rib cage having to be opened, the heart having to be stopped, the patient cooled, and all that sort of stuff. So we tend to be quite blasé about it, but it's big stuff. And it's a lot more intrusive, obviously, than just having a stent done, which is all done just normally through an incision in the groin and fed up through the circulation that way. But these are big, big changes that have just happened in the last 20 or so years in terms of cardiovascular intervention.
What did the people who are dying after they've had their stents and haven't had an increased lifespan, what are they dying of?
I think they're dying of ischemic heart disease because they've still got, a vulnerability within their vasculature. So whilst you have opened up the area that's been giving them the angina, you can't stent the whole circulation, so they're having a subsequent cardiac event. And of course, if you're a heart attack, you have to watch the terminology here. The heart attack is not a medical term, but myocardial infarction is when an area of heart muscle dies because the blood isn't getting through to it, and that's what gives the patient this crushing chest pain, the sweating, and all these sort of things. And if the area of damage is sufficient, the heart will stop pumping and they'll die. But the more common thing is that they have a cardiac arrest, where the area of heart muscle has produced electrical malfunction, and the heart starts fibrillating, starts not pumping properly, but just flickers like that. And that's where in casualty, you'll see them saying, stand back, you get the paddles out, and you shock them to get them back into normal rhythm. And that's what defibrillators do. And they're out in the community. I don't know, do any of you guys have them in your practice? I wouldn't suggest you probably do need them, but you see them now out in the streets and stuff in areas. I mean, I have a caravan over in Crail, which is a tiny wee sleepy seaside village, and there's 3 out in the street. I think they know I'm going for coastal walks. But they're very easy to use. They tell you exactly what to do. So if you had somebody there and had a defibrillator, go for it. You just rip their clothes off and put the stickies on their chest, and it tells you exactly what it needs to do. And that shocks the heart into hopefully a normal rhythm. There is, of course, the possibility that they're in asystole. In other words, their heart stopped completely, and that's just a flat line on the ECG, and you can't start that again, really. There's a slight problem with Casualty, the program I'm talking about. I can't stand it, but Miriam, my wife, loves it. I said, you must be an expert in medicine by now. And it's this idea that people, 20 minutes after being defibrillated are up having a cup of coffee and talking. Your chances of survival are pretty slim, and very, very slim if you're not defibrillated within minutes. So you've got about 4 minutes before the brain's dead, you see, and you're wanting just to keep the circulation going. So that's why you do compressions and stuff like that. Breathing's not so important, they reckon now, which is good, because quite often the patient will be vomiting, and that's not what you want to do on a Friday night in Sauchiehall Street. But if you do the compressions, well, the best thing is the defibrillator, get it straight on, but within minutes, and it has to be within minutes, because the survival time goes down, exponentially if you don't. How did we get into that? Well, anyway, that's the reality. Yeah, I wouldn't suggest you need defibrillators in your consulting rooms, but most medical centres now should have them, because it's very indefensible. They've got them in golf clubs and supermarkets and all sorts of places. And in a medical centre, you may have talked the patient down with heartburn or something like that, and they keel over and they've had a heart attack. And it's happened to me in the waiting room. Luckily, we had a defibrillator there, and it was amazing. The patient survived well, because we were obviously able to do it within about a couple of minutes. Questions? Hope I haven't made you anxious. Right, medical treatment of cardiovascular disease. Well, it's very similar to hypertension. Beta blockers, again, to stop the heart overstraining. I've talked about the GTN, and there's other types of tablets which are long-acting ones. The GTN we spray under the tongue. It's just a very quick way for it to be absorbed, and it's got longer shelf life than the GTN tablets, which went off within a matter of about 2 months. The sprays last a lot longer. We've again talked about the calcium channel blockers. The amlodipines and stuff like that, which are anti-anginal things. And then there's potassium channel activators. Again, don't ask me how they work, but they work on a different channel within the heart. There's Nicorandil, and Icoral is the other trade name for that. It's a newer anti-anginal type of tablet. And then, of course, here we go, your aspirin. Definitely, you'll have virtually everybody who's had a previous MI will be on aspirin to thin the blood, to just try and keep it flowing as well as we can. And then they're on clopidogrel or Plavix, which again acts in a synergistic way with aspirin. In other words, they both help each other to thin the blood. It doesn't need to be monitored, but they are more at risk of bleeding. And if you've got a patient on clopidogrel, Plavix, they're quite likely to have had a stenting done within the last year. Different types of stents have indications as to how long you'll keep them on the Plavix. They shouldn't be on it normally long term, but often they're after a surgical intervention, they're on that just to try and lessen the chances of clotting. And again, they'll be on a statin. Whatever your cholesterol level has been prior to your heart attack, you'll almost certainly need a lower one. And so that's why virtually everybody after a heart attack is on a statin if they haven't been on one before. And after a myocardial infarction, we need to reduce the cholesterol. They say try and get it down by at least another 25%. So whilst you may be quite happy with your cholesterol of 5 or something like that, I don't know if you've had it checked, you'll want to get it lower if you've had a heart attack. And beta blockers stop the heart overstraining, and ACE inhibitors are cardioprotective, which are very useful drugs, and they've only been in for about 20 years or so. That's after heart attacks. Heart failure is something which is, well, it's been around obviously, but it's more common now because people are surviving And these are people who are, basically their heart is not pumping as well as it should. It's just pump failure that for various reasons it's not giving the pump, the oomph to get round the circulation. High mortality. You've got to remember that if somebody has significant heart failure, their chances of surviving for 5 years are a lot less than if they have been diagnosed with many cancers, for instance. We tend to forget that you won't get life insurance if you've got significant cardiac failure, because your chances of dying within, say, 5 years are very high. The causes, well, valve disease, as I said, because obviously you've got a backflow from a leaking or a narrowed valve, puts pressure on the heart. The commonest is ischemic heart disease, up to about half the people. In other words, the heart muscle has been weakened because blood is not getting through into it, so the heart is not as strong as it was. And then you have these cardiomyopathies like HOCM. Do you know what HOCM stands for? Hypertrophic obstructive cardiomyopathy. And these are the sad cases that you hear in the Sunday morning football match or something like that. The 16-year-old boy has just suddenly keeled over and died. It tends to be familial, unfortunately, but that's where people get a hypertrophic, means extra thickened, as you know. So they have a thickened heart muscle and will suddenly stop, often in exercise. And that's why some people, and I can understand why, bereaved families are there are charitable groups out there to make sure that every person has their heart screened, but it doesn't fulfill screening criteria, and that the pickup rate would be so small. But it's so very, very significant, isn't it, for these poor bereaved families? But it's quite a thought. And then you can get heart failure just by over-treating, where you slow the heart down too much, for instance, with a beta blocker. And then arrhythmia is very common, and atrial fibrillation is one of the commonest, where the heart beats with an abnormal sort of, it should be going lub-dub, 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 and it's going all funny. That's atrial fibrillation. And it's very common in the elderly population, and that's one of the reasons why people are put on warfarin. Because obviously if your heart is not beating in a steady way and it's doing this funny thing, you can get a clot formed in the heart chamber, and then it shoots up into the brain and gives you an embolic stroke. It's a major risk factor for stroke. So that's why people are put on blood thinners, and typically warfarin, who are in sustained atrial fibrillation. So you've got to think about that in terms of your medical history as to why they're on various things. Because your population, because you're weighted like we are, you don't see, I know you see lots of fit people, but you tend to see people with pathology, and the older group, a lot of them will have these sort of conditions like atrial fibrillation. AF. You okay? You with me? Risk factors, again, for cardiovascular, it's the same thing, the same bus stop. You see them sitting there. They're boozing, they're coming out the boozer at night, they're smoking, they've got diabetes. Again, we'll come on to that, we'll cover it before coffee, because of the damage that diabetes causes to the blood vessels. And again, obesity can cause the diabetes. They've got raised blood lipids. And LVF on echo, the ultrasound is the only real way you can tell if a patient has left ventricular hypertrophy. The left ventricle is the main pumping chamber in the heart, and if it gets thickened, it's obviously trying to work to keep the heart pumping, and that's an indicator of problems. Treatment, well, again, we try and reduce the fluid load. We give them the water pills, we give them the diuretics, we treat them with the ACE inhibitors, your lisinopril, your captopril, because as I said, they're cardioprotective and they help the efficiency of the heart pumping. We give them beta blockers to stop the heart overstraining, and we give them digoxin, which helps not only to control the rhythm, but helps contractility of the heart.